I'd like to start by describing some elements of research that are absolutely essential if AI approaches are going to actually improve health for real people. Here's what I'd like to show you today. Not just who you are, but where you live really matters when it comes to your health. Where you live has a powerful influence not just on your access to care, but whether you're at risk for diseases like cancer in the first place. And we won't make the progress we need on a national level without a much better understanding of what it takes to be healthy at the local level. Next slide. The map of the U.S. age-adjusted rates due to cancer has looked like this for a very long time. And it's actually getting steadily worse for some areas. For people who live in Summit County, Colorado, a high mountain community that is the location of the Breckenridge and Keystone ski resorts, the age-adjusted rate, cancer death rate, is the lowest in the nation, 64 per 100,000 people. By the way, as a result, by the last census, it's also the county in the nation that has the highest life expectancy, a whopping 91.7 years. Let's all move to Summit County, Colorado. The worst place for cancer, according to the latest data, is Union County, Florida. This is a rural community that contains several correctional institutions where the age-adjusted cancer rate there is 270 per 100,000, four times higher than Summit County. And the average life expectancy there is 67.4 years, 23 years lower than Summit County. Next slide. It's actually not the worst place in the nation for life expectancy. Believe it or not, there's worse. So, and this is particularly awful because we've made so much progress in some ways. Just since I began my own career, the overall age-adjusted death rate from cancer in the United States fell by 34%. And that means that 4.5 million people became cancer survivors due to advancements in treatment, early detection, and smoking reduction. And I'm one of those grateful survivors. But how many, why have so many been left out of this progress? Next slide. We started talking about precision medicine with the launch of the Human Genome Project. There have been tremendous strides in understanding human biology over the 2 decades since the human genome was first sequenced. Not only better understanding of the code that provides the building blocks, but also recognizing that the genome is just the beginning. Just the basic underpinnings of what we need to know to understand health and disease with enough specificity at the individual level to deliver precision health. Next slide. Our health is governed not only by the genes we inherit, but by the environment that we find ourselves in, with that environment producing powerful influences even before our birth. Here's a recent example. Multiple sclerosis has about 200 inherited susceptibility loci. But we now know that its primary trigger is something we've known from the cancer world for a long time: infection with the Epstein-Barr virus. A driver of not only MS, but also Burkitt lymphoma, nasopharyngeal lymphoma, especially in East Asia, and diffuse large B-cell lymphoma, and most recently, very strongly associated with some gastric, hepatobiliary, and even lung cancers. Uncovering these important relationships took a combination of very large and long-term epidemiology studies, molecular immunology, and advanced antibody profiling. Both B-cell lymphomas and MS can now be treated effectively by new cell-based therapies that block production of harmful antibodies by reducing the number of CD20 positive or CD19 positive pathogenic B cells. Prevention of both MS and Epstein-Barr associated cancers across the front is counting on the arrival of an effective and safe vaccine. Next slide. Here's another example from my world of colorectal cancer of how it's important to understand components of the environment both at an individual and a population level. Early onset colorectal cancer, defined as the development of the disease before age 40 or 50, is clearly on the rise in the United States. The etiology of this change is very likely environmental. A large multinational team led by researchers at UCSD just this last year examined colorectal cancer genomes from 11 countries on 4 continents to investigate whether variants in the process of acquiring the somatic mutations in the gut could contribute to the geographic and age-related differences in colorectal cancer incidence. And they found that mutational signatures produced by a genotoxin known as colibaxin are 3.3 times more common in individuals diagnosed with colorectal cancer before age 40. These signatures were imprinted during early colorectal cancer development, and one of the signatures, ID18, is responsible for about 25% of APC driver indels in colibaxin-positive cases. Amazingly powerful evidence that this bug promotes cancer. Colibactin is produced by certain bacteria that reside in the gut of approximately 20% of people in the United States. And the incidence of colonization varies considerably across different countries, high in the US and Europe, low in South Asia. Following this very strong association, the next questions we need to address are, how are children exposed? Because this exposure happens early in childhood and then an additive effect as one ages. How are children exposed to colibaxin-producing bacteria, and what can be done to prevent or mitigate the exposure in the first place? Are their diets or lifestyles more conducive to colibaxin production? And how can people find out if they already have these mutations in their gut epithelium, the ID18 signature, for instance? Next slide. Leaving aside for now how recent advances in genetic manipulation to combat or helping us combat disease, these are incredibly exciting, but they're really still at a nascent level. When we're talking about populations, we really can't yet do much about the genes we inherit, other than use them as a predictor of risk. So with the goal of keeping people healthy now, we focus on environmental factors that influence health. Not only features of the physical environment, but we're increasingly understanding that the social environment is very important. And that's very difficult to pin this down. Some things we know for sure are bad for us. Tobacco use, too much sun, too many martinis, excessive caloric intake. For other things, our suspicion is high. We don't have the smoking gun yet, but our suspicion is very high. For example, does PFAS exposure cause cancer? So we're getting worried enough about this to try to raise awareness and try to eliminate forever chemicals from our environment. And there are other associations with disease that are evident from human epidemiology, really evident, but the precise mechanism is not well known yet. We know about these largely because they are seen in the setting of health disparities. Next slide. Research tells us very little, if any, of the geographic very little, if any, of the geographic association between cancer incidence and death is due to inherited genetic tendencies. Instead, we must consider effects from the physical environment like air pollution, pesticides, and other chemical exposures, and also the social environment and lifestyle factors, diet, exercise, tobacco, access to affordable care. Many regionally distributed threats can really do, for those of us who love fundamental biology, really do affect DNA, protein levels, signaling pathways, and metabolism, some directly and others indirectly through relationships that we're still trying to understand. Emerging data, for example, on epigenetic inheritance show that the environment can influence our health beginning with conception. At the top are next slide, please. At the top of this are maps from the National Institute on Minority Health and Disparities showing U.S. distribution for cancer incidence, deaths from all causes, and deaths below age 76 across the top. These are statistics that we generally use to think about on a very large population level how we're doing. And remember, this one on the left is cancer incidence. And below, you see some repeating, overlapping patterns. There are variations, but in general, you see that regions with higher rates of adverse characteristics shown on top are also locations with more air pollution, more families in poverty, and more smokers. Next slide. The same outcome indicators are on the top here, and now you can see an opposite geographic association with factors that help us be healthy, where people have better access to healthy food, higher educational attainment, higher percentage of people with health insurance. And one more, another slide. Colonoscopy adherence, access to broadband. Hopefully this one's getting a little better. And do people get a flu vaccine? The inverse to where people are not healthy. Next slide. I have some very personal reasons why I'm so invested in overcoming health disparities. It's not an issue I was deeply involved in professionally until recently, but I now realize it has been part of my experience my entire life. I grew up in rural Wyoming, where the ranch that our family lived on was 90 miles from the nearest healthcare provider. And employer-based insurance was not an option since we ran a family ranch. The employees were my 4 siblings, my mom, my dad. I wanted to be a doctor because I adored my uncle, who was a primary care doc with the Veterans Administration and took care of vets all across the state of Wyoming, including the Wind River Indian Reservation. You can see its location here on the map, very close to where the ranch is. Next slide. Went on to a career in academic medicine in Boston. As you heard, I took care of patients with cancer and established a lab to study inflammation in cancer. As a junior faculty member, I was frustrated by the divide between the clinic and the laboratory. So I began to study the biologies of tumors using samples obtained from patients during their participation in clinical trials. Then I had data on both sides of the equation, the biology of the disease and very well-defined clinical outcomes that a clinical trial could provide. Some modest progress in linking the laboratory fully to the clinic has been made over 30 years or so I've spent on this work. But this goal has gained much more urgency as we begin talking about really achieving precision medicine, providing the right treatment to the right patient at the right time. It quickly became clear that there is so much more to providing the right treatment, right patient, right time, than just analyzing DNA and protein expression in tissue samples. Next slide. So during my time at NIH, I was drawn back to my roots. Here I am on the NIH campus last fall with Karina Walters, a member of the Choctaw Nation of Oklahoma, who leads the NIH Tribal Health Research Office. And then here on the right, I am with my Uncle Pete and members of the clinical care and research team of the Eastern Shoshone Tribe on a visit to the Doyanatsu Healing Center in Fort Washakie. This amazing community receives funding from NIH for its research to combine ancestral healing rituals with the very best mainstream medicine and disease prevention and treatment for a community whose people suffer tremendously from poor health. Next slide. We must find the will at a national level to do more about health disparities. One thing is obvious: we need more research. There is so much more we can and must do to understand how our physical and social environments influence health and how we can bring positive results to those who today are missing out. Comparison with other nations is also telling us that healthcare doesn't need to be so expensive to give us good results. We need to learn how to make needed services more efficient and understand what changes on a societal level are needed. We can't let the fact that societal change, cultural change, is very difficult. We can't let that stop us. I'll just give you an example of an amazing societal and cultural success from the cancer community. Our tobacco cessation initiatives. So tobacco is such a social thing. How much progress we've made there. We can do this again and more. Next slide. I hope that the maps I've shown you have convinced you that health is a local issue. something that must be optimized to meet the needs of individual communities. What works in Sweetwater County, Wyoming, is not the same as that in Suffolk County, Massachusetts. I have personal experience as a patient in both locations, and I can tell you that both of those places have a lot to learn from each other. Our research goal is to learn how to develop effective care for everyone. And to do this, everyone needs the ability to be part of research. To do this, we must conduct research that is not just patient-centered, but also community-focused. And we need to link clinical research to care delivery. Next slide. Let's start with clinical trials. Since this is an oncology community, the research that delivers the greatest confidence in the clinical relevance of results. And this is essential for having confidence in new therapeutics. This map shows where cancer clinical trials are available. And you're going to see another similar pattern here. Note that the counties in white have no trials because there are no oncologists there. And look at the high concentration of trials in places where other maps have shown that outcomes are much better. It's often said that those participating in clinical trials receive the best care, and this is consistent with that assertion. It also tells us that we need much to bring more research to the communities who need better outcomes and better care. Next slide. All of you know this slide, disparities in research inclusion. This is just clinical trials inclusion, but it really matches research overall. They match those in health overall. We're missing important data from older people who live in rural sites. They lack insurance coverage, belong to a minority group, have a very rare cancer, or have more than one disease. We should not be surprised at all that this list describes characteristics of people who are experiencing health disparities. Next slide. So now I'm going to get specific. Here's my wish list for all of us. What would help us tackle health disparities, improve health for everybody? Number one, more clinical trials, including those that help us really understand the environmental and societal causes of cancer and poor outcomes. Real-world generalization of clinical trials results. Take the results from clinical trials conducted in major centers of health research and find out if they also work for other populations. We've already seen this in AI. A nice tool that works very well in the big hospital doesn't work in the clinic down the street that has a completely different demographic. That's really sobering right there. Wake-up call for all of us who are excited about AI. Do people also, here's a really good question. Do people also experiencing disparities even receive the better care that a trial has determined? Understanding how and when people receive what is known to be best care is essential if we're going to improve health for them. Next, we need easier, better, and much less expensive longitudinal cohort studies. I gave the example of MS and Colibactin for a reason. These are powerful results that never happened from the lab until we understood the epidemiology. And to understood the epidemiology, in the case of Colibactin, took the whole world practically. We need to do that much better. And, the health professional study, the Framingham Heart Study, all of these studies followed communities for decades, but they were unbelievably expensive, long and difficult. They don't need to be that anymore. We have data technology that can truly transform the ability of every single person in this room to contribute their data to a longitudinal study. And it's cheaper, it's easier, it's better. Why are we not doing it yet? We can talk about that at the break. And we could do so much more to directly compare healthcare utilization. I don't mean the claims forms that go into CMS. I mean, what did the hospital do? What did that patient actually receive? Down on that elemental level. Compare that to how they were. What was their outcome? I will bet you that what did you do to what was the outcome equation is going to have to be completely different in Sweetwater County, Wyoming, than it is in Summit, in Massachusetts, in Boston. And that's okay, because we're going to be optimizing for the people in the communities where they live. Okay, science is helping us develop better ways to identify and measure health-related environmental exposures and societal factors that are so important to health. And finally, and most of all, we need a learning health system approach to knowledge generation, innovation, and implementation. Every community is unique. Every community must be actively and continually engaged in learning what succeeds. I go back to the experience at Doyanatsu until NIH came in with this long-term program. We're helicopter in and out of our Native American communities. There was nothing durable there that raised the level of health in those communities, and that's one of the things that I was very passionate about fixing while at NIH. Next slide. Over the past 20 years, the National Academies of Science, Engineering, and Medicine have been working on a comprehensive program. This is 2011, this thing, for the development of a learning health system. Progress must be made on many fronts for this to be achieved. One example, a critical component not yet well adopted was highlighted almost 15 years ago in this Academy's report. This stated that to deliver the right care to the right patient at the right time, the definition of precision medicine, we needed to integrate research data with clinical data. Not just which gene predicts which drug should be used, but to include all relevant data, including the many environmental and societal issues that determine whether an individual can thrive. Next slide. During the 20 years since the learning health system concept was championed, technology that can help us has advanced tremendously. AI is the most striking example of this. AI depends on data completely. So it is an essential beginning is to develop a safe and reliable way to link at an individual level clinical outcome data from a patient's digital records with the many other important data sets relevant to health. Such a system which deliver what people really care about, because this is the only way a learning health system that has the trust of the people we serve, patients, clinicians, and researchers, will be able to succeed. Next slide. Today, the healthcare industry generates 30% of the world's total data volume. 30%, just healthcare. And the average hospital in the United States produces 50 petabytes of data annually in the form of clinical notes, labs, medical images, sensor readings, genomics, and operational and financial records. AI is driving great progress by helping us capture data now from text files. Can read image and biometrics, annotate genomic data, and integrate very diverse data sources at an individual level, faster and cheaper by far than what we have had in the past. Next slide. But inability to access the data we need remains a major limitation. Progress is also happening here. Through its leadership consortium, the NAM has championed the concept of health data as a public utility, a utility that will include everyone and can be used to improve health for everyone. We have seen impressive progress toward implementing the data access defined by this concept, driven by both federal government and private sector activities. Next slide. Okay, let me end by addressing the challenging times we find ourselves in today. So much is happening in the world of health, care, and biomedical research. On the one hand, we're seeing new advances at an astounding pace. Cancer vaccines, gene editing, AI-driven protein classification, and drug discovery, all with the promise of dramatically improving disease treatment survival and even cures that we couldn't dream of before. On the other hand, we're seeing a loss of trust in science and medicine. We're worried about the state of our public health system and experience a time of serious disruption in the biomedical research enterprise. We wonder if everything, including even our health, might be taken over by AI-powered bots. Next slide. As I said, our experiences with tobacco cessation and COVID taught us that culture matters when it comes to health. when I was growing up, the ranch we lived in was not only 90 miles from the doctor, it was 90 miles from school. We lived full-time at the ranch all summer, and when the school year started, my mom moved me and my 3 siblings down to the town of Rock Springs, Wyoming, a ranching and coal mining community with a population then and today of about 20,000 people. From grade school to high school, we went back to the ranch every weekend until the snowfall caused the animals to move down to winter pastures closer to town. Just last week, this article about Rock Springs, where I went to high school, was published by NPR. This is Dr. Bonu Symington, a medical oncologist who has practiced in Rock Springs for 30 years as the only medical oncologist within a 3-hour drive. This article states, I urge you to read it. This article states, Symington is among many doctors who say political attacks on science and medicine are affecting their relationships with their patients, particularly in rural communities where physician recruitment already poses a chronic challenge. Increasingly, misinformation and conspiracy theories about health fill a vacuum that's created by a lack of doctors, adding challenges to care. The article goes on to describe how Bonu's patients with neutropenia from their chemotherapy have cursed at her for suggesting that they wear masks and ended up in the ICU due to complications from their covert use of ivermectin. At a recent county fair, she stood for 4 hours offering to anyone free vials of sunscreen. One woman, and no, she got no takers. Nobody wanted the sunscreen. One woman asked her, "You want to know why?" And then told her that she believed doctors have been putting cancer-causing chemicals in sunscreen so that people with get cancer and doctors can make more money. My first reaction on reading this article just last week was, these are not the people I grew up with. But after thinking about it a little bit more, yes, these are exactly the people I grew up with. Fiercely independent and self-reliant, preferring to find their own way in a rough part of the country, and currently living where healthcare providers are increasingly scarce and the vacuum is filled by social media. These are my people. So, next slide. Medicine is founded on a really sacred concept, the trust that is earned by human-to-human interactions. I don't see us trusting AI for our care. Using its amazing capabilities, absolutely, but hopefully never, ever eliminating a caring human being from the loop. I'm so encouraged by results of surveys asking people who they trust for their health decisions. And the top of the list is always the primary care provider. Next slide. We live in a very divided nation right now. I am sure it is not lost on anyone in this room that the maps I have shown you today indicate that health disparities also fall along political lines. I can't think of a more powerful way to bring people together in this time of a terrible division and to restore trust in medicine and science overall than to focus on eliminating these disparities. At the core of any strategy to do this is the clinician-patient relationship, a relationship of trust that focuses on the health of individuals. And in clinics every day, these human connections do transcend cultural, political, and social boundaries. Next slide. This ring of stones is a 10,000-year-old, you can see it right here in the foreground, is a 10,000-year-old medicine wheel located on a hilltop in the Great Divide Basin overlooking Rock Springs, Wyoming. This town is far in the distance. Over in the rocky outcroppings above it in the back is an ancient burial ground. For the ancestors of the present-day Shoshone Nation, This medicine wheel was used for ceremonies whose actual intent we can only infer from the long Shoshone tradition of engaging the entire community in practices that seek healing for each of its members. The vision at Doyanatsu today, for instance, is that healing is sacred work not just for the individual, but for the whole community. We bring our knowledge, our skills in the clinics and operating rooms, our research, our political policies, our administrative acumen, but all of these are just the means to an end in a uniquely human endeavor, caring for people. Not in a paternalistic way, but with empathy and compassion and an understanding that we're all in this together and we can't leave anyone out. Thank you very much.